Hi, everybody. It's Susan Clinton with my co-host, Erica Mello. Hi, Erica.
Hi, Susan. How are you?
Great. We just wanted to introduce a couple of things before we get started on podcast number 105. And the
Mhm.
couple of things that we wanted to talk about was our new website is up, www.toughtotreat.com, and our opt-ins are there. And we'd love to get
Yes.
you on our email list because our subscription, the podcast club, is going to be coming this fall. I know we've kind of talked about it all summer. I had a little bit of a change of plans as I'm moving to northern Michigan because my husband retired from the university this year. And so I'm still actually in process as we kind of are still nomads across the country before we move in. But the subscription is coming. So keep an eye out for it. And the people on our email list are going to hear about it first. So we want
Yes,
everyone
absolutely.
to jump in. Erica, do you have anything you want to add before we move into the podcast?
No, we still when you opt into the website, you'll get our clinical pearls PDFs and also sleep and chronic pain. They're great resources. We want to thank everybody for continuing to leave us a testimonial. We really appreciate it. Wherever you listen to your podcast, whatever platform you have, please leave us a testimonial if you found value with our podcast. We love doing this, and it warms our hearts when we read the testimonials, truly. And we want to thank everybody who has left one.
Yes, thank you so much for the testimonials. It really helps other people discover us as well. And
Yes.
the final thought is that you can always email us, Erica at ericamello.com. And now my new email address, we announced it, I think the last podcast, Susan at ltiphysio.com. So that's where I will be. That's where my information and email correspondence is starting to land. So I welcome you over to that platform with me. Enjoy the podcast. Hi, everybody. Welcome to Tough to Treat, episode number 105. I can't believe we're at 105, but here we are. I'm Susan Clinton, your co-host, along with my co-host, Erica Mello. Hi, Erica.
Hi, Susan.
And Erica is moving into September in New York City, and I am traveling in the Western United States. I just landed at Yellowstone in transition from Pittsburgh to Northern Michigan. So let's just talk about what we were going to talk about today for this podcast. Let's dive right in.
Let's do it.
I chose this one. This has been a complex patient that I have treated in the past, and very interesting presentation. But it also, I decided, it also became kind of a little bit of a learning tool, I feel like, for people as well. So I'm just going to dive right in. You know how we always talk about looking for drivers and kind of what's going on. This is one who has a few things that are happening all at one time, which kind of made it interesting, but also very frustrating for her because nobody was really helping her put the whole picture together. So this is a 67-year-old female, a very, very highly cognitive functional individual. I'll leave it at that. You know, very smart, still working, very, very engaged in her work. And she's also somebody who's very slight of frame, and just she's just not a big person. She's just a little tiny person, very strong, very healthy, individual. She presented, she had been told by a couple of people to find me, and she presented with kind of an interesting combination. She first started telling me about, pointing to her right perineum around her ischial tuberosity. So she would trace your entire ischial tuberosity. And then she would say, and then I have a hamstring issue. It's like, how do you know you have a hamstring issue? Because an MRI showed tears and degeneration at the hamstring tendons in my pelvis. So part of the hamstrings, attach up into the sacrotuberous ligament. It's not, she's 67. This is not an unusual presentation on MRI, but it's in her brain, of course. And that's what she was told. So she, really had no reason to question it. And then, so she, the biggest thing was, though, this is just around my perineum, around this ischial tuberosity, especially when I sit. And, and I think it's because my hamstrings are torn, and, but her so we'll get into that in just a little bit into the exam part. And then, after just kind of listening to her and talking and just kind of getting to know her a little bit better, she started talking about having some left lower extremity pain. So this was on the right, the presentation around the perineum. And then on the left side, she had some, what she called kind of vague, she goes, I think I have a disc. And it's like, how do you know you have a disc? Well, I have this kind of nervy pain that kind of comes down the side of my leg. And, but, she goes, I really notice it when it comes down below my knee into my foot. When it's just on the side of my leg, it's not a big deal. But when it comes down, below my knee to my foot, it really bothers me. So, and just really kind of continuing to talk, she said that she'd had the left-sided nerve pain for a while, at least a year and a half. She's had the perineal pain for a little longer than that, but it got really bad a year and a half ago. So I started kind of thinking, it's like, what happened a year and a half ago? Like, what was going on at that time?
Exactly.
Some pretty significant things happened. She had some big issues with moving. There was a lot of stuff around a big move. There was some stuff around a death as well. So there was a lot of big things that happened at that time for her. And so we just talked a little bit about, some other things. Who is she seeing? She saw a urologist. She saw a gynecologist. She recently saw a urogynecologist. She has seen an orthopedist. And she said, I really have spent most of my life not being ill, and now I have all these problems. And I said, well, tell me about your other problems. And so she talked about, having some constipation and some things like that. And that the urologist put her on Detrol because she goes, I feel like I need to go to the bathroom all the time. And I said, how long has that been going on? Well, that started, her story was that started about a year and a half ago. Same time everything else was going on. And so, when you hear the words, and some belly pain and, just the whole thing kind of starts to really sound, and if you look at that central sensitization inventory, or what we call nociplastic pain now rather than nociceptive, could have had a nociceptive beginner, but it was very nociplastic the way it's behaving. And she has those markers that are in there for that. So, I just kind of started asking her some questions. When did this all start? And so she started telling me this story about how she sits on her chair and that she would deny herself the ability to go to the bathroom. That went on for like about 20 years until the end of the day. And then she would have to like literally press on her perineal area in order to kind of release enough so that she could actually go. And now, of course, the opposite has occurred. She's gone into where her bladder is, she's got this urgency frequency. So she feels like she has to go all the time. And that's why they put her on the Detrol, which probably is not helping the constipation issues, of course, either, because it can be a constipator. So we have a lot here to kind of unpack and talk about. But the biggest thing was, listening to her story. We're thinking, okay, so she needs some bladder voiding. We need to do a bladder diary. We need to kind of see some of these other things that are happening, but it was pretty clear to me that I don't know where this may have started, but it started sounding very, very much like a visceral driver to me, which, we don't talk a lot about on the podcast, but we see that sometimes. People can have, illnesses and, things and end up with, belly pain and bloating and IBS, from just the whole system being taken offline for so long. We see this after chronic injuries and, different things, really a lot of trauma, stuff like that. Well, that, sometimes, the viscera being and dysfunction can create somatic, issues. It can have a somatic presentation as well. And, it started to kind of sound a little bit like that with me, but I started with the movement system. Go ahead. Yeah, please.
No, could she sit okay? Could she sit down with, she could sit, okay. So she had no problem sitting hard.
Yeah, she didn't like it. And if she was already hurting, then sitting was a real problem. So here's when sitting's the worst. Sitting is the worst when she sits too long and when she drives.
Okay.
Yeah. So
driving and sitting too long. Okay.
yeah, right.
Got it.
But here's the other part of the story. I don't know how long is too long, because, you know, if I sit, you know, when I sit, I notice like the next day it'll be bad, and then the next day it'll be worse, and the next day it'll be worse. So it starts to sound a little bit like it has an immune type of piece to it, which is, you know, that's the people who exercise and don't know, you know, they feel okay when they're exercising, but 2 hours later they don't feel good at all. You know,
Right.
like their, you know, their symptoms really increase. That's the immune response, you know, that happens there, which is very typical when you have a, you know, when you have the nociplastic type of stuff going on. And there's a lot of
Yeah.
things that were happening for her all around that one time that, you know, maybe this would have come on anyway, but it definitely got exacerbated about that, you know, year and a half mark, when all of those things were converging at the same time.
Yeah. So what makes you think so? Okay, go ahead.
No, go ahead, ask, go ahead and ask.
No, so what makes you think it was visceral? What clues in her story?
The clues in her story about not allowing herself to urinate, and then having a very difficult time urinating, you know, so it's like, so her bladder was being taught to act in a way that is not usual or normal for bladders to behave. But it's what we see with nurses and school teachers and healthcare providers and,
Right.
you
Right.
know, people who just don't take the time or don't feel like they have the time, not even a
Right.
minute, to go to the bathroom.
Right.
And, you know, and that can, you know, and if she had to press on her pelvic floor in order to you know, initiate urination, to, you know, to get enough pressure to get the pelvic floor to probably relax. So it sounded like that her pelvic floor had already started becoming an over recruiter in response to this, you know, this retention of the urine over the day.
Yep. Yep.
And you know, and she said that, you know, when she sits, if she sits in a certain position, she's a very small person, that it makes it worse. So usually when she's like all perched up on a chair with a little bit of an anterior tilt, she feels better if she can grab her right leg and flop it over the side of a chair at home. You know, it feels more comfortable. She cannot find a good place to sit in her car. And, you know, because that really bothers her. So the first thing that we started doing, of course, I did all the pelvic health things, which was, please fill out this bladder diary, you know, tell me a little bit more about, but try to be as specific as you can so we can kind of see what's happening here. I need a little bit of information about what you're eating. Let's be sure you're chewing your food and getting things in. And, you know, are you doing anything for your constipation? Because that could certainly make this worse. And, you know, so we had some discussions around that, and, you know, making sure she's not eating inflammatory foods. We talked a bit about bladder irritants. She, you know, I sent her the whole list and information on that, you know, and I said, tell me where you want to start with this. You know, tomatoes were the big thing for her. She was like, that's going to be probably the biggest thing that I'm doing. You know, when I look at this list, this is a big one for me. Yeah. So, so she wanted to start eliminating tomatoes out of her thing, and she knew she needed to start changing her coffee drinking. She was drinking lots of coffee during the day.
Yeah.
And she's up all night going to the bathroom. You know,
Of course.
she's not, you know, was not allowing herself to go to the bathroom during the day, so her sleep was all knocked off too, which doesn't help when you've got an irritation in there as well. Yeah. And so, you know, but so that is there, and, you know, we discussed, you know, alkalizing her water a little bit, and, you know, just making the you know, the habitat for the bladder a little bit more friendly on the inside. And then, you know, so where I wanted to go right away was into visceral mobilization, but I didn't, because I thought I really need to make sure I'm not missing anything here in this picture. So we did our normal thing that, you know, we do. I had her stand just normally, and I said, I want you to stand comfortably like you always do. And she was very good at conversation, so she just kept talking and I just kept watching. And one of the things that she did consistently over time while she was standing there telling me another story was that she would either stand and drop into like a really flattened lumbar spine with a really posteriorly rotated pelvis, so super extended hips, right? But it was almost like the pelvis was jutted forward. Like it wasn't just posteriorly rotated, it was like ahead of her femurs.
Anterior.
Her pelvis was anterior of the femurs, but still in that posterior. So this jutted forward, you know, kind of positioning.
That's hard to do.
Yeah, it is. It's really hard to do, but she could do it very well. And then she would switch
Huh.
from that position. She would stand and cross her legs and jut it forward some more. Very small person, so she had, this
Yeah,
kind of
yeah.
movement. And it was interesting because it was the right side that was jutting forward more than the left,
Mm-hmm.
as I
Mm-hmm.
kind of watched this.
Yeah, yeah.
So I started looking up and I started looking down.
Yes.
And one of the things that I noticed was she was really, really, really back on her heels. And she was back on the right heel much more than the left heel. So she was really kind of like, like this whole thing, this pelvis jutted forward more, and she was back on that right heel a little bit more. And it caused her thorax to kind of do a little right shift also.
Yeah.
So
Yeah,
I just
yeah.
made note of that. And all I did was starting her again with like, let's just do a couple of things right here. She was already irritated because it took her for, she had to drive to the clinic. So driving was her big thing.
Yeah.
So I had her lay down for all of the conversation we had so things could calm down. Well, everything's going to bother her because it's already irritated. I said, okay, I'm looking for things that bother it more. And I realized that you have this line of pain that's going on right now. We're looking for things that make it worse. So, I just had her stand differently. I said, can you, she goes, people have told me all the time to bend my knees when I stand. And it's like, okay, well, let's don't do that then. Because it apparently didn't work.
Yeah.
So,
yeah,
it's like,
I'm just thinking how she can maintain that posterior pelvic tilt and standing the whole time.
And so all we did was we just did some things like, where are you on your feet? The various stories we've talked about in our podcast. But I basically had to spend some time with her on just kind of, being able to transfer weight off of her heels onto the balls of her feet a little bit, and to really notice when those gastroc muscles kicked on.
Yeah.
And she did notice a change in her symptoms, and she wasn't jutting forward as far with her pelvis, and she wasn't doing some of these, and they're just habits. This is classical conditioning at its best. She just stands up and this is what she does. She's done it forever. And and then crisscrossing her arms on her chest, kind of the smart girls look, and so we just worked on changing some of that and doing some of that, and that started to make a little bit of a difference with her, which kind of got a really nice entry for her to kind of just like, let's just calm this down, let's do the things that we can to calm it down, and let's just keep working along this track. That's where I left her that first day, because there was a lot to unpack, and I really wanted her to get her head around some of these bladder irritants, and to really spend some time filling out a fluid log for me so I could see what was happening. And I told her, I said, don't make it perfect, just whatever comes up in the day, just write it in. When you're going, count how long you go. You may go 10 or 15 seconds one time, you may go 2 another time. Just write it in. It's okay. It'll help us see a pattern. And so and I sent her a bunch of information on that, and out the door she went. But it was interesting because she started to catch on as we were doing the thing, the credit card and all, goodbye, and let's set the next appointment and everything. She caught herself about 10 times going right back into that really, dominant posture that she has. So we, so we kind of got going on that. The other thing that I left her with was, I don't, if it's at all possible, at the end, of 30 minutes, if you can stand up for 5, that would be great. If you can't do that, at the end of the hour, you have to get out of the chair. You have to give yourself a break. You can't sit for that long, because, we just don't know how long. And so let's try to start exposing, keeping you exposed to sitting, but not 4 and 5 hours at a time.
Especially if she's sitting in a posterior pelvic tilt, and hamstrings posteriorly tilt the pelvis too.
Yeah, exactly. So anyway, so that's kind of where we left it. So the next time she came in, I did much more of a bigger exam. We did the lumbar flexion, we did a lumbar extension, we looked at the thorax. I looked at, her feet had changed a bit. She was really working on kind of changing that. She was still off on that right side quite a bit, but not as bad. It wasn't as rotated as it was when she came in the first time. She still had some pain because she had driven to the clinic, and so that actually I was okay with that, because if we could figure out a way to settle it down, that was a good thing. So through the exam, we examined the hamstrings, we examined the length and the tension and the strength. We did not find any problems whatsoever. Good motor control of her left foot and her right foot. Does she have some sensory stuff? Probably. Yes, she definitely, you could tell that if she spent a lot of time sitting. I asked her, this question, how does it feel below your knee when you're in the car? Oh, it's much worse. How does it feel below your knee after you've been sitting all day? Oh, it's much worse. So we did some extension. She didn't want to do it in standing, and I didn't want to feed into that whole kind of weird postural thing that was going on. So we just got her on the bed, and I said, just prop up on your elbows and tell me how you feel. And that definitely took the pain down that was in the side of her leg. It took it down. Hard to tell if it changed the perineum at all. It did change it some, but it was really hard to tell. Again, that immunity thing, after she does something too long, kind of tends to linger. So I said, well, let's figure out a couple of other things then for, because that'll help that pain down your leg. So when you can, if there, let's figure out a way that you can do this after you get out of the car. So I'm putting my thinking cap on, trying to think, how can I do this without her jutting that pelvis forward again?
Right, exactly.
But in the meantime, I said, let's take a look at, let's just do a, thing and get you into child's pose. And, so we did, and then we kind of did, with, the heels together and the knees apart. I can't think they call that wild child or whatever, but we just increased, like we do with, standing, narrow, wide, together, And so that felt really good. And, I helped her put a pillow in the front of her pelvis as she, went down into that position. We got her to breathe some and relax. And that is when you could really tell that the thorax was really kind of like tilted, the right rotated a bit. And I thought, we've got a little bit of work to do in this thorax here. So, so we did that. And then I taught her how to do the doorknob standing squat, where you hold on to the doorknob with your arms extended, and you do a sit back squat. You go as low as you can. She loved that. That felt really good.
I'll bet that was probably good for everything.
Yeah, it felt really good. And so we tried it with narrow, we tried it medium, we tried it wide. She liked wide the best. That was fine with me. It didn't kick up her leg, so I was okay there. It actually made her perineum feel a little bit better. So hooray.
I was going to say, yes, exactly.
So then the next thing we did, the very next treatment she came in for, so that was the second one. And I will also tell you that I gave her things like cat-cow on her hands and knees. We explored, lower trunk rotations, some different things, but I wasn't quite ready to dive into the thorax with her yet, because there was just, her attention was on the lumbopelvic leg region, and I wanted to keep it there for a bit. Go ahead.
Yeah, Susan, her forward bend was normal. Her lumbar flexion was normal. Okay, and she didn't exhibit any kind of symptoms or no, like posterior lean or anything like that. Okay.
I suspect that if I put her in that position for a long period of time, it probably would have happened. But I, with just bending, and I already know that sitting's a problem, and I've already watched her sit. So we're changing the way that she sits and changing some things there. So the third time she came in, we had the fluid log and we went through it, and we talked about how to even this out and how to, slowly hydrate throughout the day and not wait till 4 o'clock and start gulping water, and making some of those changes. But then I wanted to go ahead and do some visceral, just some movement of her viscera, just to see if any of this caused her any problems. And it was really very interesting. Once there's a technique where you can get, just above the pubic bone onto the bladder, and
in supine
with the legs, in supine with the legs over a pillow, just comfortable, calm. And, as soon as I started working viscerally with her bladder, or the tissues around her bladder, or the nervous system around her bladder, you can call it whatever you want to call it. Exactly, but as soon as I got into that region, that increased her perineal pain.
So your hand was where now, Susan?
So my hand was so her pubic bone, you put your fingers on top of the pubic bone, and you just come up towards the belly button so that you're in the soft tissue of the abdomen as it attaches to the pubic bone,
Got it.
right where the bladder lives.
Yes.
So just
Got it.
moving things around, moving neurology around in that area was really quite tender, quite significant, and really that brought everything on.
So just like doing a listening with your hands there brought her symptoms
just
on.
doing some some side to side movement. We call it kind of mobilizing the vesical ligaments that hold the bladder in place.
Yes. Yep.
So, and then over towards the left of the pubic bone into her sigmoid colon. That was very tender too. You could feel lumps of stool there, so still very constipated. But a lot of this brought on her left kind of nervy pain. And you have to think about that. The colon is retroperitoneal, and can irritate soft tissues, fascia, nerves, anything. So it was interesting that it brought on that symptom when we weren't in a position to bring on that symptom. It didn't really go down below the knee, but she said that's making this happen. And so that's why visceral driver. So here's where the story goes a little sideways. So it kind of sounds pretty simple now. Treat get the bladder under control, treat the viscera, get movement there, all this stuff, and life will go on and be good. Well, in the meantime, then there was a break I had to take because I was out of town. And in the meantime, unbeknownst to me, she went to go see another PT, which is totally fine if she wants to go do that. But the other PT spent time with her and told her that everything that I had told her to do was wrong and that she needed to completely quit any exercises whatsoever and only concentrate on her transversus abdominis. This is somebody who walks miles. This is somebody who is very active and very healthy. She's very strong, but she said, your pelvic floor won't get better until we get your core stronger. This is somebody who can plank.
Oh my God.
He can plank. She did something. So anyway, so we had it, so I'm putting this out there because if anybody's listening to the podcast, it's like, we really need to meet people where they are and stop telling people to stop doing everything. I am aware her obturator internus is kicked up. That's why she's standing the way she's standing. And, it's one of the muscles that's involved with urinary retention and urgency frequency. I get it. But there's also the viscera that's very, very important too. And the driver was not a musculoskeletal because my core is weak, my pelvic floor is over recruiting. That was not the issue here.
Exactly. It's not an overactive superficial system and an underactive deep system. That was not the driver. That's not the impairment, so to speak, right?
Right. They were secondary. And we're in a nociplastic type of situation here. So you don't want to take them away from stuff. You want to expose them. You want to be careful. I wanted her to not stop sitting, but I wanted her to sit differently, and I wanted her not to sit so much at a time. And by this time, we've been into this now for about 5 weeks. And by this time, she could tell me very specifically, if I oversit, I'm in trouble. When I do the things I need to do to get up, I do much better. It's driving now. It's only driving that kicks up my pain. Everything else is so much better. And I said, well, then you need to make a decision about which way you want to go. So she, after a while, again, highly cognitive functional person, really wanted to understand why this other person would say this and this, really wanted to open it all up and talk about it. And
I would have lost it right there.
I was just like, let's just, you just tell me, what it is. It's okay. And we'll just kind of move on, with the story. So regardless of everything else, she decided to stay with me, which is fine. And we continued down the visceral driver path, but I added in the thorax here. And mainly because I felt like that she was just, and that was the other thing, is that she wanted me to push my belly out when I breathe. And I'm like, if anybody out there knows Susan Clinton, it's like, we want the whole system working. This person is already fighting with it, with this other stuff. And now you want to press on it with extra breath. It's like, no. But anyway, I took that as a cue and I said, well, let's talk about breathing just a little bit and let's do this. And so we got her on the wall, because she could feel her back a little bit better.
Yeah.
Thorax on the wall a little bit. We bent the knees, we bent the hips a little bit to take all that other stuff out of it. And, and I said, tell me where you feel the wall the most. And so we just kind of played around with that. And so she kind of got into the thing. And then, because she was doing so good with it on the wall, her breathing started to change anyway, just because she was just in a better position. And, so I grabbed some TheraBand and I said, just grab hold of it and pull it apart a little bit with your two hands and just, hang there with it and just keep breathing and see how you do. And then we just got up to standing and did some standing. And then I took the TheraBand away and I said, let's just how are you, where are you with your standing? How's that going? How's that happening? And, so she felt like it. She goes, I still catch myself. I still cross my legs and shove my pelvis forward. But the way that you got me to change it is still work. So I'm still working on it. And I said, okay, let's do this. Let's put that TheraBand, grab that TheraBand and pull it apart again a little bit. And, and see how that feels in standing, and so that helped. She was like, it feels different, so it's like, okay, so this is good. Well, remember everybody, all of the nerves that come out of the thorax go into the abdomen and down into and the lower abdomen into the, there's still, the bladder still has, connections from L1 and L2. And, and certainly the lower colon does. So, here we go. We're right at that area and that junction where that rotation may be occurring. Right. But, just being, again, adaptive creatures, we adapt till we can't. And then she had
and also with, and also, I'm sorry, so with driving, she's got her arms on the wheel. Right. And so she's probably, I'm just, I'm not going to harp on the positioning, but when you have your arms involved and, on a close chain, you gotta explore the thorax just a tad, I think it makes sense with her story,
And part of, I think, the driving issue, as I got to know her better, was she's a very nervous driver. So there's a lot more to that part of the story too, but she's just a very nervous, driving was not a comfort zone for her. And so here we've got somebody with, but no, it was good because we talked about that. I said, I'm wondering what's happening in the car. So we got back in the car again and, tried to kind of settle her up on more of, she's got a bucket seat. We filled it up with a denser blanket and said, let's try to make this more like a bench seat. And, and just kind of just show me like, which hand do you put on top of the steering wheel? What do you do? And so what she usually does is she would like lean onto her, middle console, a lot, and so
pattern.
So we kind of talked about, can you lean onto your door, your door handle on the other, the elbow pad on the other side a little bit.
Exactly.
Just start, kind of, changing things up and trying to help, because it's just going to be, that was like the biggest sticking point still was driving is still the biggest problem. But we got her where she was doing a lot of different exercises. She had some exercises she didn't like. If she didn't like them, we changed them. She took her a while to understand with the cat-cow and lower trunk rotations and movements that don't keep pushing into when you feel that pulling on the left side or this happening here or that happening there. Just stay to the edge of it and, keep moving, but, keep it without going all the way over. She just really needed a lot of redirection and a lot of those things. And we spent a lot of time with that. So by the time I finished with her, it was really, really quite nice. She still has trouble driving, but she's so much better. But all of the other stuff has really markedly improved. And she really started to understand about, I need to hydrate better. I need to, I need to stay away from some bladder irritants. One of the things that I'd like to do with her in the future is see when she talked about wanting to get off the Detrol. And I said, I think that's a perfect thing to do. You'll let me know when you're ready. And, your urologist, I know her urologist really well. And I said, they would be very supportive of that. It was just there as kind of a bridge for you. And now that you're, you've crossed that bridge, why don't you just wait and see, and let's see how your symptoms keep changing and improving. But, she was also reassured that it's okay to do the exercises that she wanted to do. Those exercises were not bothering her. They were not giving her pain. She was not painful with them. The number one thing that bothered her was sitting.
Right. So you did like the visceral mobilization. You gave her, you worked with her on her center of mass over base of support, getting her more forward. You gave her the door squats, and then you had her do cat camel in different positions of normal, narrow, wide. And then you had her stand with the TheraBand wrapped around her forearms to sort of maybe see how her nervous system adjusted to that position. Is that okay? Yeah, yeah, yeah. And
So
she didn't continue to do the abdominal exercises, did she?
no.
No, yeah.
She was fine. She was strong. She could do like a full leg,
Totally.
you know, her legs straight, like lowering down to the bed. She was like
I
fine.
know. Oh,
So, you know, and it's like, I understand, I totally understand when you do have a real, you know, underlying underactivity of something and the global muscles have taken over. I totally get the where that can work, but this was not the case. This was a case of the drivers were very different here. And, you know, at first I thought there's probably a foot driver in here because of the way she's standing, but it wasn't. It was definitely a, you know, it was classical conditioning, but it was definitely this visceral pattern that, you know, for her not to pee, you know, and not allow herself to pee, that probably set this whole thing off. And the thorax was the secondary driver in there because she couldn't stay, you know, like I said, and the way that she took one leg over helped her rotate her thorax backwards on the right, you know, that right rotation. And so, you know, just doing the other stuff wasn't going to change it. It wasn't going to get her, it wasn't going to get her moving differently over her feet. And it certainly wasn't going to, you know, really take care of the issues that, you know, were happening in the bladder and GI system.
No.
And, you know, but the biggest thing is that, you know, the thorax would have never been treated. And you can, you know, and you and I have talked about this a long time, you know, that people can have a primary and secondary drivers, and they're going to reveal themselves. You know, if it was not a thoracic driver, it would have gone away once things started getting better, right?
Correct.
But it wasn't. It was still there. You know, and
Yeah,
sitting was still a problem, but sitting in the car was really the problem.
Yes, exactly.
And so really having to get into that was, you know, if we didn't do that, it wasn't going to change anything.
Yeah, you know, it's funny because there's such a strong relationship between the thorax and the pelvis. And do you remember, I forgot what podcast number it is, but I've been, I think it's for the listeners, it's leaking and running. Remember one of my patients we had on, she was postpartum about a year, Jackie. So for the listeners who just start, whoever, you know, if you haven't listened to that one, it's called Leaking and Running. I think it's in maybe 40s or 50s or 60s at this point, but she was also way on her heels, and it's a great another podcast, another episode to listen to after you listen to this one, because it puts together that whole center of mass piece as well. It's fantastic. Listen, because it's me and Susan and my patient. So anyway, that's you know, that's just throwing that out there. It's so fascinating. It really is. And you know, you always think, and she actually had a foot driver, Jackie, because there is that relationship as well. So this is a fascinating case. I've taken some visceral work at the Baral Institute. I've not done the pelvic part of it. I've done, like, you know, visceral 1, BM1, BM2, and you know, some parts of that, but I think that's just fascinating. And you know, what's great is that if you can still stand in a posterior pelvic tilt, but you need to be able to move out of that position. You know, if you can't move out of and if that becomes your dominant position, that's a problem, you know?
And especially because it was perpetuating everything else.
Yes.
You know, so, and, you know, it was hard for her to change it, but she did. She made it through and she's doing good.
Awesome.
Yeah, we're getting there.
Awesome. Well, yeah, awesome. Well, thank you, Susan.
All right, everybody.
Yeah,
we look forward to listening to your comments and your questions, and keep in mind that the subscription to our podcast, which is coming soon, the Tough to Treat Podcast Club, we're going to have every month a live Q&A. So, and you don't have to be there to listen to it. Send in your questions. We will answer them. We will discuss them.
And
if
when
you
have
there, and you've applied in time, you can you know, we'll have one person do a hot seat. So we have opportunity for more interaction.
Yeah, and you can, as part of the membership, you can access that anytime. It's like a regular podcast. It's just going to be a part of you'll have a separate feed, a different podcast membership feed. So more details to come, but that's awesome. Thank you, everybody.
Bye.